It's about a very controversial issue, and I think the mainly controversial issue about this part is it really that the pregnant patients are continuously losing their babies, or is it really that the doctors are continuously losing their pathways in the middle of guidelines that are changing every year? So first, I would like to point to one slide which can be irrelated to the talk. It's actually about repeated implantation failure. There was a very big meeting that was held in Lugano in 2022, including the most eminent reproductive endocrinologists in the ISHRI and the ASRM, to find out what is the reason for repeated implantation failure. And did you know what was the conclusion of this meeting? The conclusion of this meeting was that the condition called repeated implantation failure actually does not exist. There is nothing called repeated implantation failure, because even the patients who fail to implant free euploid embryos as per definition, if they proceeded to do another IVF with another free euploid embryos without changing anything, 95% of them are going to get pregnant. So we concluded that if there is a rare condition that makes embryos does not implant, this condition can never exist in more than 5% of the IVF population. And we all know that the IVF population is 20% of the infertility. So if such a condition exists, it does not exist in more than 1% of the population that we are seeing now. Okay, now this is the cornerstone of my philosophy of the presentation. In any medical condition in the world, there is always the price of doing nothing. If you know that you have diabetes and you do nothing, there is a price you're going to pay. If you know that you have a heart condition and you do nothing, there is a price that you have to pay. But here, I want you to look on the chance of a successful pregnancy after the patient aborted 3 times with doing nothing. Nothing. Now, I will ignore the first line because this is 20 years old. This is very rare. Let's speak about the third line, the green 30 years old patient. If she have aborted 3 times before and she decided to get pregnant the 4th time without doing any intervention, she has an 80% chance of having a successful pregnancy. So the most sophisticated intervention that we know is what? IVF, PGD. What is the success rate of IVF, PGD? 40%, 45% in the best hand. The cost of doing nothing is 80%. So this is the first time that we have a medical disorder that actually no treatments gives better results than the most sophisticated treatment. So first of all, let's speak the same language. What are we considering repeated pregnancy loss? Because before, the Royal College considered that only patients who have 3 consecutive abortions to be repeated pregnancy loss. This includes only 1% of the population. But the recent guidelines say that we will include patients if they aborted once or twice, 2 times, and they should not be consecutive, and they can even be from 2 different partners. So all the data we have are going to be obtained from these guidelines, Australian, German, Green Club guidelines, and ISHRI guidelines, and we all accepted this definition. So what do we all proclaim? So now we are going to be speaking about the workout for repeated pregnancy loss. I want you to take consideration that I am coming 10 minutes. I am going to change your mindset from how can I do all this workout to do I really need to do any workout for this patient? So first, let's speak about what does the guidelines agreed upon. All agree about lifestyle modification, while the only the ISHRI emphasize the importance of underweight, which is a very big problem among Generation Z, who are the most common patients who are getting pregnant now. Let's speak about vitamins. Do you consider that supplementing patients with folic acid decrease the incidence of abortion? Actually, no. Supplementation of vitamin D? Actually, no. We decrease, folic acid is recommended to decrease the incidence of open neural tube defect. It does not decrease the incidence of abortion. But if folic acid is not beneficial, it is definitely not harmful. So this rare condition does not actually exist in medicine. It exists only in the Egyptian social media. The Medfer mutation is an imaginary condition that we have imagined, created, and believed ourselves. While the CDC guidelines states clearly that there is no condition whatsoever in which a patient will be harmed by giving folic acid. So the idea of giving patient folate that costs 1,000 pounds instead of folic acid that costs 10 pounds is pure commercial among Egyptian drug market. It does not exist in the medicine whatsoever. What else is pure commercial, does not exist in any guidelines? Measurement of natural killer cells, HLA, cytokine. The screening for hereditary thrombophilia, this is the workout that any woman who aborted twice will do. It's cost around 10,000 pounds in Egypt. It is not recommended at all. Only the ISHRI stated that ANA can be used to guide the patients who might benefit from receiving steroids during pregnancy. Might benefit? Does this mean that patients who aborted 3 times does not benefit from corticosteroids? Not only corticosteroids. The policy of giving any patient who aborted twice heparin and low-dose aspirin is not supported. Corticosteroids is not supported in the management. All the fancy medication that you are nowadays hear about, Prograf, Dupagent, IVIG, they are not supported by any evidence whatsoever. Okay. As regard antiphospholipid syndrome, we all know that antiphospholipid syndrome causes repeated abortion, and we all know that antiphospholipid syndrome is treated by aspirin and heparin. But anybody knows what is the real incidence of antiphospholipid syndrome among patients who have repeated abortion? When they defined antiphospholipid syndrome according to the Sapporo criteria, it was estimated that 15% of repeated pregnancy loss have antiphospholipid syndrome. The recent European American guidelines, when it is applied, it was concluded that 1.5% of repeated pregnancy loss has antiphospholipid syndrome. In my country, I do not know a patient who has aborted 3 times and is not receiving Clexane. So this means that 98.5% of the patients are receiving Clexane for no medical background. There is no role for prescribing corticosteroids, and there is no role for therapeutic doses of heparin in the management of antiphospholipid syndrome. The only condition that is proven to be benefit in resistant antiphospholipid syndrome is Black-Anil, and it is not stated in other guidelines. But what about inherited thrombophilia? Very recently, the Royal College advocated that maybe cases that have second trimesteric, not first trimesteric abortion, might be implicated hereditary thrombophilia forms in some of these cases. So they are not advised to be screened in first trimesteric abortion. They can be screened in repeated second trimesteric abortion. Okay, what about the uterine causes? We all know that patients with repeated pregnancy loss has more incidence to have uterine anomalies. But do they need to be treated? Actually, the gold standard for diagnosis now is the 3D ultrasound. It is not the hysterosalpingography, and it is not the hysteroscopy. As regards the congenital uterine cause, only the removal of uterine septum has proven to be of any benefit. Metroplasty, no role. Unification of bicornuate uterus, no role. Let's speak about something. Prophylactic cervical cerclage in the absence of evidence of patulous os definitely is harmful and not beneficial. Harmful. Okay. Here are things that are going to get really, really strange. As a laparoscopic surgeon and a hysteroscopic surgeon, I assumed that any patient who aborted 3 times and has a polyp or a fibroid, it must be removed. Very strangely, only the German guidelines advocate this policy, while the biggest societies in the world, RCOG, ISHRI, found no evidence in the treatment of any acquired uterine pathology, even in the context of repeated pregnancy loss. But I would argue that this final line might be due to financial controversy. This will be a very influential topic in guidelines, because if the guidelines say that removal of fibroid is beneficial, then it must be covered by the insurance, and the financial concern will be high. So endocrinal condition, we all know that uncontrolled diabetes causes repeated abortion. Controlled diabetes does not cause. Uncontrolled thyroid problem doesn't causes repeated abortion. Controlled doesn't. But what we all don't know is this middle line. I want you to see this middle line is very controversial. The entity of subclinical hypothyroidism is definitely related to repeated abortion. But what is subclinical hypothyroidism? All the current evidence says that an abnormal TSH is when the level is exceeding 4. In Egypt, all the labs consider TSH from 4 to 5 to be normal. So this is my fight in the clinic every day. Every day, you try to convince a patient that she is having TSH of 4.5 is not normal, and she keeps on telling you the labs say that it's normal. While all the data, ISHRI, RCOG, consider this patient to be abnormal and must be treated. So patients who are having TSH more than 4 must be treated in this context. PCO. We all know that PCO causes repeated abortion, but we don't know what to do about it. So use of metformin, no role. Does the high LH abort more than the low LH? No. Does the high androgen abort more than the low androgen? No. Androgen testing, not beneficial. Luteal phase support, this was controversial issue because one of the bigger studies was the PROMISE trial found no role for progesterone. But then they later on, they modified the recommendation, say, okay, there is no role for progesterone until the patient starts to develop threatened abortion. Once she develops threatened abortion, she must be receiving progesterone not only till the stopping of the bleeding, but till the end of the 4th month. Infection. This innocent creature was for a very long time #1 suspect of all abortions in Egypt. It does not cause abortion except in Egypt. It is not a cause for repeated abortion except in the Egyptian clinics. No evidence that any torch infection can cause repeated abortion. Chronic endometritis is a very, very, very common condition in America. It does not exist in Egypt. Why? Because in Egypt, patients tend to take antibiotic when they are shaving their beard. They take antibiotic when they go to the barber. So it is quite impossible that a condition that sophisticated that will pass untreated while its only treatment is to receive vibramycin for 7 days. So this condition can never be a cause of repeated abortion among Egyptian patients because you will very rarely see an Egyptian patient who has never received a course of antibiotic before. This is the diagnostic test for the chronic endometritis. Sperm DNA fragmentation, it is proven that it causes repeated abortion. What is not proven? What is its management? There is no proven management. So why do I diagnose a condition? I know that it's influenced, but I cannot do anything about it. Now let's speak about the cornerstone. What they are not telling you, when the patient aborts, she is aborting at the moment the pregnancy has happened because it happens wrongly. So embryonic causes or genetic anomalies actually cause 60% of abortion. And if we are speaking about first trimesteric abortion, this number will rise to 83%. And can I extend my time by 2 minutes? 3 minutes. So why can we are not able to diagnose this huge number of chromosomal anomalies? I will tell you a very quick part. When we were used to analyze product of conception by karyotyping, we found out that 40% of the product of conception was abnormal and 60% was proclaimed normal. But when we developed and we started to do more sophisticated tests like CGH, we found out that 60% of the product of conception are abnormal, and now 40% are considered normal. So when we develop again after 30 years and we develop a new test, we will find out that 90% of the product of conception are abnormal and 10% are abnormal. And you might expect in 100 or 200 years to find out that there is nothing called the normal abortus, that all these abortus are actually chromosomally abnormal. It is just we do not have the technology to diagnose it. So now the current guidelines, the American College recommend that any woman who have aborted twice must start her workout by analysis of a product of conception. Because if this patient turn out to be aborting abnormal babies, there is no need to screen her for antiphospholipid. There is no need to screen her for abnormal uterine cause. There is no need to give this patient Clexane for 9 months. There is no need for her to continue a workout that will cost 30,000 pounds. She is actually aborting in a defensive mechanism. Her body is protecting her against getting pregnant in abnormal babies. While only around 40% by the modern technology, there will be more than that, that might require this workout. Okay. Now, a very recent evidence in this year suggested that we will divide the patients into 4 groups. So these are the patients who have abnormal genetic cause, and these are the patients who have abnormal maternal cause. And here is where they meet. These are patients who have both maternal and fetal cause. And according to this definition, you will find that what was called unexplained repeated pregnancy loss affect only 8%. Okay, this is a very complicated figure. Does it add anything? No. I want you to look at the management, expected management, expected management, expected management, expected management. So actually, finding a role or finding a cause will not change the pathology and will not change the workout for the patient. أنا هجري بس شوية عشان الوقت أنا عارف. When is IVF beneficial in a patient who have repeated abortion? We have a very few number, 5% of patients who have repeated abortion have a condition called unbalanced translocation. This is the only patients who can benefit from IVF even if they are getting pregnant normally, because you can choose the embryos who does not have the chromosomal abnormalities. Time. So, should we offer IVF for any woman who have balanced translocation in her parents? I will give you 2 examples of patients. This is Mrs. Vicky. She spent around 200,000 pounds every month in shopping. And this is her servant, Mrs. Fakia. Her earning is 200 pounds. We both have balanced translocation. We both have the same condition. So Mrs. Vicky will choose to do 2 cycles of IVF PGD. This will cost her 120,000 Egyptian pounds. What is their success rate? 50%. While her servant will choose to do nothing because she does not have money to do anything. What is her success rate? 70%. Okay. This lady is going to take 6 months to reach the desired healthy pregnancy. This lady is going to take 12 months, only 6 months longer to reach the desired healthy pregnancy. The most important thing is the borderline, the last line. They both have the same chance of delivering a normal baby. So even after the patient has paid 120,000 Egyptian pounds, she still have the same chance of delivering an abnormal baby like the patient who has paid nothing. So before this slide, على فكرة بس, this is a very good slide about the integrated approach. First, I wanted to present this slide to say that this patient has paid 120,000 pounds for nothing. For nothing. But when you have another look, try to convince this lady, tell her, I want you to spare the 120,000 Egyptian pounds, but لأن خلاص أنا خلصت أنا كده خلصت. Just get pregnant 4 times in the coming year. You will abort 3 times, and the 4th time will be a normal pregnancy. She is going to tell you are crazy. I pay 120,000 pounds on buying shoes. Why don't I pay them to buy happiness? Why do I need to abort 3 times? While in the same time, if you try to convince this lady to pay 120,000 Egyptian pounds to avoid the despair of depression, she is going to tell you are crazy. I am living in depression. I don't mind to abort 3 times. So this lady, The management can be tailored according to the different scope of the patient. Some patient will found that the management is beneficial, and others will say that the management is not beneficial. So these are the beneficial interventions, these are the non-beneficial interventions. And the most important thing is the prognosis. I want you to remember one thing. If you did nothing to the patients who have aborted 3 times before, 75% she will have a successful pregnancy in the next time. Thank you so much.